Hello, everyone. Good afternoon, and welcome to Fighting the Infodemic, Fake News, Public Trust, and Public Health Policy panel discussion. This panel discussion will bring together experts in medicine, public health, and journalism to discuss ways to ensure the flow of reliable information about COVID-19 and serious public health threats. The program is a joint effort between students and faculty in the journalism and public health departments at the College of New Jersey. So we welcome you. We thank you for joining us this afternoon. I am Dr. Natasha Patterson, Assistant Professor of Public Health, along with Kim Pearson, Associate Professor of Journalism and Professional Writing, and our students in health policy and in journalism. We are excited to have you this afternoon, and we're looking forward to hearing from our panelists today. So just a quick foundation around infodemic. So as you saw in our title, according to the World Health Organization, an infodemic is an overabundance of information, some accurate, some not, occurring during an epidemic. It makes it hard for people to find trustworthy sources and reliable information when they need it. Even when people have access to high quality information, there are still barriers they must overcome in order to take recommended action. Like pathogens in epidemics, misinformation spreads further and faster and adds complexity to health emergency response. So with that, I would like to introduce our panelists for today. And in the meantime, we would like to ask you all to be sure to ask your questions, put your questions in the chat, and we will have an opportunity for you to ask questions when the panelists finish. So our first panelist, Jacquie Bishop, is a Black, gay, Native New Yorker, New Yorker living in Boston. Her journalism has appeared in Bay Windows, Philadelphia Gay News, The Village Voice, Women News, and various other gay and alternative presses. She has over 50 poetry publications. Jacquie started her public career in 1983 in the West Village, the epicenter of the HIV/AIDS crisis in New York City. She has focused her work on health education, programming, and policy. Oliver Brooks, Dr. Brooks received his undergraduate degree in chemistry from Morehouse College and his MD from Howard University College of Medicine, and completed his residency in pediatrics at Children's Hospital, Oakland. He practiced in underserved communities of North Oakland and Richmond for 4 years before accepting a pediatric position at the Watts Health Care Corporation, where he presently is Associate Medical Director and Chief of Pediatric and Adolescent Medicine and Chairman of Quality Management Committee. Dr. Brooks is a medical director of Jordan High School-based health clinic and chairman of Immunize LA Coalition, leading the group for more than 10 years. Melanie Kron is senior producer, Dr. Radio, Sirius XM. Melanie Kron is the senior producer at Sirius XM Pandora's Dr. Radio program, where she has covered medical and healthcare news since 2008. Prior to Sirius XM, she was a medical consumer and breaking news segment producer and news writer at the Fox News Edge, the national affiliate newsfeed service for 130 Fox affiliates, and an associate producer for WebMD TV Weekend. Airing on Fox News Channel, she began her career with the Science and Technology News Network as an associate producer and digital video editor.
Right.
Melanie is a graduate of the George Washington University School of Media Public Affairs, where she also studied pre-medicine and exercise science. She's a Philadelphia native who has lived in New York City for the last 20 years, but still loves cheesesteaks and will always be an Eagles fan, and believes the word John should be officially put in the dictionary. David Mindich is the chair of the journalism department at the Klein College of Media and Communications at Temple University. Before that, he was a journalism professor at St. Michael's College in Vermont, where he served nearly a decade as chair. The author of 3 books and numerous articles, including ones in the New York Times and Wall Street Journal, Mindich was named Vermont Professor of the Year in 2006. For the 2015-2016 academic year, he was on sabbatical living in New York City and working as a visiting scholar at New York University. Before becoming a professor, Mindich worked as an assignment editor for CNN and has an earned doctorate in American Studies from the New York University. So I just want to say welcome to our panelists. We thank you for taking the time to join us this afternoon and share your expertise, your perspective on this very important topic. So my first question for you guys is, it's a 2-parter. So what were you doing before the pandemic was declared a public health crisis? And how did the nature of your work change once we moved into this interesting time of our lives here? So we can start with, we can go in the order of introduction. So Jacquie, would you want to share?
Sure. I work for a national organization, AARP. That's the largest organization focusing on issues of concern to people 50 plus, and I do programming there. I was in my office. About a week before we were shut down, I was actually in New Jersey and Philadelphia assisting my sister and who had just had surgery. So we were beginning to hear some things. And there were a couple of cases that had hit New Jersey. And my public health, senses started tingling. And it was like, ooh, this is going to be bad. Got my sister situated, came back to Boston. And my office, our national office, had told us, take your laptops home on Wednesday and test them and make sure you can work from home, just in case. And I think I'd come back into the office that Tuesday. So Wednesday, I took my laptop home. We came back into the office on Thursday, and we left on Friday, and we haven't been back. So that was, I think, the second week of March. Working at home for me has been fabulous. I have to say, I love it. I have the support of my staff to do, we've had to pivot in programming, so we're not doing any outpacing programming. And so going online and producing events has been really pretty easy. The technology piece, there's had to be some ramp up of understanding of how do we do this and how do we interact with our members. And given that a large portion of our members are considerably older and may not be as tech savvy, how do we not lose them if we are going to just be doing things online? So it's been a learning process, but I've been able to focus more on the type of programming. I've been doing a lot more people of color focused programming. I have a panel next week that we're producing on hunger and COVID in the Latino community. We just did one in the African American community. So I'm living my best life. I hope we never go back to the office.
Oh my goodness. Okay, well, Oliver Brooks, would you want to share kind of your take on how things have been going for you?
Yeah, certainly, and good afternoon to all here and assembled. I apologize for my tardiness getting on the call. I actually was and kind of am to my left on a hypertension call with the Surgeon General and just spoke to him regarding that. So I had 2 roles. First of all, good for you with the AARP. So I'm actually I want to weave that in, Dr. Bishop. So right before it hit, I had 2 roles. I was Chief Medical Officer at an FQHC, a Federally Qualified Health Center, Community Health Center. And so, we were going about our usual, making sure that we're taking care of our patients and making sure our productivity is up, credentialing physicians, dealing with the nurses, staffing issues. And then this hit. So we went from seeing, let's say 20 patients per provider per day down to 1, or 2. So we had to pivot to telemedicine. And during this time, we have come up, but it was a whole sea change. Number two, we had to deal with infection control of the staff coming in, convincing people to wear masks, physical distancing. So all the aspects of that, even now, I get emails every day, every other day. So and so was exposed. You know, were they 6 feet away for 15 minutes, masked, unmasked, and go through the CDC data for LA, so LA County Department of Public Health. So that has been a major challenge, and there's a lot more that I won't get into there. Other thing that is more relevant, and I thank my sister Kim Pearson for calling me. I was president of the National Medical Association. So National Medical Association represents the 50,000 African-American physicians. So, you know, as president, the main things I was doing was planning a colloquium, which is where we get together and we go up on Capitol Hill and lobby after it's advocacy. So we determine things we're going to be focusing on. And then the second thing was planning our major convention. Our biggest event is getting, you know, 2,000-3,000 people together. We were going to be in Atlanta. So COVID hit. We canceled our colloquium, so we weren't going to go on Capitol Hill. We had to cancel and pivot to having a virtual convention. And we pulled it off. We had Stacey Abrams, Anthony Fauci, and a number of very good presenters. My mandate was my platform was being maternal mortality, prevention of gun violence, and increasing the African-American physician pool. Most of all, that just went away. COVID was a grenade, a nuclear grenade. I wrote an article. I was asked to write an article for the National Newspapers Publishers Association, Black newspapers. I said COVID-19 and Black people. That was the title I came up with. And I just said, I bet you this thing is going to hit us harder. We didn't have any of that stuff yet. That was March 31st. Between March 31st and April 3rd, when I came out of office, all I did is live and breathe COVID-19. All the levels of COVID-19 as it relates to the Black community. I like your stuff, and Infodemic, fighting infodemic stuff. All of those things that you're talking about was my life. So it changed. So I'll stop there because we got other panelists.
Thank you. That sheds a light on just a different perspective from what many of us have been living. So thank you for that. David Mindich, you want to share?
Sure, and thank you, Professor Patterson and Professor Pearson, for the invitation. So happy to be here. So on March 11th, Temple closed. I was teaching a class where I brought 30 students up to New Hampshire during the presidential primary. And so I had just gotten back. The class ended. The rest of my colleagues were still teaching, but my class was a half semester class. So I said goodbye to them in the end of February, and then I didn't see them again because we closed on March 11th. When Temple announced the closing, I grabbed all of my research on the cholera epidemics of the 19th century and brought them home. I've written about cholera and the way it was reported and the way it was treated. And so I knew that there would be it would make sense to bring it home. And then I began to read and write more about it. In late May, after the killing of George Floyd, I then collected all of my research on one of the central figures that I've studied in my career, Ida B. Wells, an anti-lynching crusader from the 19th century. And I spent the entire summer just reading everything that she wrote and all my notes about her. And it was actually, I'm very grateful for that summer to kind of get back in touch with Ida B. Wells and to see how everything she wrote, 120 years ago, 140 years ago is completely relevant and timely, unfortunately, to what we're experiencing today. So my research was really provoked this summer and in the spring and summer by events, and it's been a very important time for me to think about a lot of these issues.
Thank you. Yes, powerful. There's a lot there to unpack. So we'll get to talk about that after we hear from Melanie Kron.
Thank you, Professor Pearson and Dr. Patterson, for inviting me to join you today. I just wanted to give you guys an idea of how we cover the news on our channel. So Sirius XM Doctor Radio basically broadcasts out of the lobby of the NYU Medical Center. The hosts of our shows are doctors who have been trained to be on air. So it's lucky that we have physicians who actually understand what they're talking about when they're talking about it, but we always bring experts onto the show, onto our programming, that are people in the field that know exactly what they're doing. So we are not at a loss for expertise and coverage. We actually started covering this, believe it or not. My first story, I did a little digging today. January 23rd was the first mention on air that we had of this. And the title of the article was Chinese City Halts All Air Traffic. Coronavirus kills 17. So 17 people were being reported out of China having had coronavirus kill them. And so we had that on our emergency medicine show, which often has the headlines of the week. We do things that are breaking news. I come from a breaking news background, so I like to cover things in the moment when they're happening and try and vet them properly before we actually bring them on the air. So my ER docs totally spoke about it. It was something that they were going to be tracking. And the next week, February 7th, on my child psych and parenting show, we covered a topic on fear of coronavirus. Now it was a little bit more in the news. People were paying attention. It was people are being cautious and they're paying attention to what's going on. And that was really where we were February 7th. And then Monday, March 2nd, my entire internal medicine show, which covers soup to nuts and everything in medicine, that we covered everything COVID. Preparation for quarantine, dispelling myths using the World Health Organization's list of myths and tips. This was what we knew at the time. Wash your hands, wipe them, walk away, and watch and get more information. We weren't even wearing masks at the time. There were no recommendations for mask wearing. But at the time, we also were asking our doctors to talk about their experience during the H1N1 flu virus that came out a little bit earlier in the 2000s, and I'm blanking on the year. I think it was around 2008. And so we were covering it from that perspective. And then that day, I remember my entire staff was at a staff meeting, and this is kind of an important journalistic moment where your journalistic spidey sense takes over. That moment where I was scrolling through my Twitter account before our editorial meeting, and I saw a doctor from Bergamo, Italy had posted about what was happening. And he was a firsthand account on the ground and saying that they were using cadaver trucks. And I have to say that the pit of my stomach dropped. I had that moment where I almost had a fight or flight moment, and I turned to the producer sitting next to me and said, "Have you seen this? This should scare us." I have never felt this on edge about something. And we've been covering news stories for a long time. I've been doing science and medical news since 1998. And it just had a feeling of like, let's really pay attention. I went home that day, went right to the supermarket because I live in New York and my refrigerator is empty except full of water bottles and takeout Chinese food. And, and I stocked up on what I thought I might need to go into a quarantine. And I called my parents who live in Philadelphia and I said, you might want to consider not going to work. I just don't feel good about this. I don't know how to stress this to you. I really care about you. I think it's going to affect the elderly. Just something in myself said this is what we need to do. And they didn't want to listen to me at first. It took a little bit of convincing, but they did listen. And basically that next week, we went to our boss's boss and said, we don't want to come into the hospital anymore. We don't want to be in the studio. We don't know what's in the air. We don't know who's been touching what. Can we work from home? And our company was amazing and let us work from home. They figured out a way to remotely broadcast, and we never went off the air. I think we might have gone off for 2 days, but they had repeats of all of the things that were all things COVID. And that brings us up to speed. We've been doing COVID every day. The news is changing all the time. And that's the nature of science. It does shift and change. So you have to just keep going with it.
Definitely. Thank you so much, Melanie. So I do want to make an announcement for the attendees. Please put your questions, use the Q&A feature on the Zoom so that you can enter your questions for our panelists. And while you're doing that, I wanted to follow up with you all about just what Melanie just said, the information is changing constantly, right? The sources of information coming from everywhere. We have social media, we have the, cable news, we have, basic news, we have word of mouth, we have so much, so many different sources of where people are learning about what to do, and we see these different ways of handling the situation. How does this impact what you all are doing in your work and in kind of your day-to-day in functioning? How does this impact you guys?
I can start. Just an hour and a half ago, we started our state planning for the year 2021. What programming will we do? And we have a matrix from our national office, and we have some general topics, but the real emphasis has been on online programming wasn't a thing for us. I think maybe, there are 53 offices across the country and parts of the Caribbean. Maybe some people were doing one or two things online, but now it's all things online. I think the real question for a lot of us is, how do we reach the people we have not been able to reach? What else do we need to be doing? What other community-based organizations or larger NGOs that we need to work with to make sure that people are getting help, getting resources, getting information that they need to be safe, to not be hungry, to not be homeless, and to also have engaging programming that can help them not isolate as we stay socially distant. It is still, it's really a challenge. I mean, it still is. There are people who just don't want to deal with the technology piece, which is really unfortunate. There are people that are trusting resources that are untrustworthy, and so we're constantly combating that as well. I think in my personal life, just making sure to have conversations with people and folks, knowing that, I lived through the AIDS crisis, in the early 80s. I was 19 years old when I became involved with that. I do have friends who are asking me, like, what do you think? What do you think we should be doing? Do I really need to be doing this, or blah, blah, blah? Just trying to stay updated on the information is really, I think, the work that we're all trying to do.
I can chime in. So the AARP had a series of webinars where they had tens of thousands of people. That's why I wanted to reference your work, Ms. Bishop. So I was a panelist on 3 of those, and they're excellent. So when you see a reputable organization disseminating information or sources of information, like a webinar, that is a great source. So for Melanie, Station 110, Sirius XM, I would listen to them. Those guys, they're out of New York, some hospital in New York. And I would listen to that. That was early on. And it evolved. They would say one thing one week, next week it would be a little different, and that's the nature of science. For me, I go to the CDC, the WHO, and for me, LA County Department of Public Health, and they will all have slightly different information. So fortunately, since I'm a physician and I'm having to live this stuff on the clinical and the epidemiological and scientific side, I just go through and kind of put it all together. I worry about people like, okay, I'm in Philly right now. My mother is 94. So I have to give her information, and I need to think about where is she going to get the information from. Were it not for me, I really don't know where she would get it from. She's not tech savvy, so she would not be on one of Jackie's webinars. She listens to the radio. So I remember watching, whatever it's worth, I remember watching CNN or MSNBC, one of those two. And they actually said, if you want really truthful information, look at us. Now, I want to be apolitical, but when I've watched media news media, I have found that I get pretty accurate information there. The real problem, of course, is the disinformation, misinformation. That's really, really hard to fight. I don't have a good answer to that. I tell people, call your doctor. And if you call, and I mean, the doctor can get in it, but if you call your doctor, ask the doctor, what should their source of information be? So for the NMA, we put information on our website early on. This is primarily for physicians, because back then it was hard to even know the truth on the purely scientific side. So it's been a real challenge. And I think the recommendation is for the people that tell them to just take information from people and sources they trust. It's a simple statement, but I really believe that that's what's going to work.
Can I chime in here? You mentioned something very interesting. At the beginning of the pandemic, World Health Organization, the CDC, all of our reputable government agencies that we go to for public health information felt like we could go to them and that we could really trust them. But I think once everything has been politicized in medicine and public health, it's been challenging. As a journalist covering this, it's challenging. And as a person who doesn't really know how to look at different sources, what sources to look at, who to talk to, journalists have access to a lot of people that the layperson doesn't have access to. Dr. Brooks, I could call you up and say, hey, can I bounce something off of you? I saw this study, what do you think of it? And if you said, not something that I would want to put out there, our channel probably wouldn't cover it. I want to make sure we're giving people peer-reviewed, good information from reputable journals, from reputable resources. And it's hard when you have this embedded distrust of government agencies, which we're in I want to call it a post-information fact age. We aren't, but it feels like we are. And it's our jobs collectively, everybody on this panel, to really make sure that we can help the public.
The thing I would add is that I'm a historian, and what I certainly read the news, and I'll listen to NPR and the New York Times, read the New York Times and watch TV news, and so I'm kind of a news junkie, but also I'm very interested in the history of pandemics and what pandemics and tragedies in general reveal about us, and so. When we see the health disparities based on systemic racism, for example, we see that revealed very clearly in the pandemic, in the same way that Hurricane Katrina, revealed these incredible disparities in New Orleans that made us, as people interested in the press, think about why wasn't, let's say, New Orleans poverty and systemic racism covered before Katrina. But yet we're also thankful that Katrina can reveal things to us that maybe we weren't as aware of before. In the same way, we can see this with COVID-19, and then, as I mentioned before, the George Floyd killing. We can again reveal things about racial inequality and systemic racism. So, I think that it's really important. Everyone on the panel, I agree with the need for accurate information, and also just to kind of offer also that we need to look at what this reveals about America and about our history as well.
Definitely. Thank you.
May I add something to that as well?
Yes. Mm-hmm.
Just very quickly. So, as I said, I'm preparing this panel for next week on Latino community and COVID and hunger. And one of the things that's very striking to me is that in the city of Boston, where I live, Latinos make up 19.7% of the population. However, they make up 32% of the known COVID cases. 32%. With the majority working in service industries. So when the shutdowns happened across the country and the city, I mean, we shut down here in Boston and Massachusetts pretty early on. All of a sudden, essential workers, as white-collared educated, overeducated, even persons got to go home, and we got to take most of our stuff home. I left my iPod, which was really the most important thing for me at work. But Latinos, women, people of color, immigrants were forced to continue working in service industries in order for us to be able to work at home. And so when we are talking about educating, you mentioned Katrina, I mean, poverty is real, right? And we don't talk about it and we don't address it because it's not attractive. I think academics address it. I think social activists, talk about it, etc. But, in terms of news, if it doesn't bleed, it doesn't lead, and poverty doesn't bleed to the general public. It does for those who are greatly impacted by it. So just wanted to share that.
To that point, there's a question in the chat from Lana. I work at a restaurant, get tested every 2 weeks, but the rapid and CRP test, both the rapid and CRP test, it's $180 for both. Not all medical facilities have rapid tests. Back in June, July, doctors told me the rapid test was said to be 90% effective. Now they say it's 65 to 85% effective. Why have doctors given me such a vast and unreliable percentage? And is 25% inside dining actually a good idea right now? Am I safe even with a mask and hand washing?
So I can address some of that. So she mentioned rapid testing versus PCR. I presume that's what she meant. First of all, there are a number of rapid tests. The rapid tests right now are designed to be what's called specific. If we think you are infected, it's very accurate, but it is not designed for screening. So what you're doing, you're getting screened every 2 weeks. So the main one is about 80 to 85%. So there's another, your third now, but that's what they are. The Abbott ID1. The PCR is 99, 100% accurate as it relates to positivity, but I don't even want to get into all the technical stuff. It's a lot of technical information out there. So that's the reason why you're getting all these different numbers. There are different tests. And again, it's evolving. We are learning more and more every week about the virus and our response to the virus. As it relates to that 25%, I think one of the main things we learned about this virus, I think is just so important, which is the thing that's the most politicized, is wearing a mask. So wearing a mask cuts down this stuff by 90%. So, you don't want to be exposing yourself. You don't want to be in a close environment. But if you wear a mask, you're really, really reducing it. One more thing, the protective masks that we wear generally protect other people from you. The N95s protect you from them. But that being stated, the protective ones, the non-N95s, still go a long way to protecting you. But if everyone's wearing a regular one, then it's clear. Now, the only other thing I'll say, which is the thing that threw me off the most, and it's not talked about much, is whether or not this virus is spread by aerosol. So way back, I had a personal belief that it probably was, but we don't really know. But that was the most significant thing that happened, is not getting a lot of discussion. That I think it was the CDC or the FDA, CDC posted on a Friday that it was aerosolized likely, and they took it down on Monday. That was the biggest thing, because an aerosolized virus is probably 8 to 10 times more contagious than just droplets. So that would have raised a red flag. So for Lana, I would say 25% indoors. If you have good ventilation, is probably okay. If you wear a mask, but my only concern is this: you cannot wear a mask when you're eating or drinking. So that's the one thing that really concerns me. I would be uncomfortable. I just hate to say it to you if you work there. I would be uncomfortable working in an indoor environment where people have to take off a mask to do what they're doing in that particular establishment. If you're shopping, you can keep your mask on the whole time. If you're eating and drinking, you can't eat and drink through a mask.
Okay, thank you so much. So we do have some additional questions in the Q&A. We have one is, how do you think the public's reaction to new information has changed between the beginning of the pandemic to now? And that's for any one of you.
I'll jump in, I guess. We get a lot of listener questions and answers, phone calls on our channel. And at the beginning, it was a lot of the kinds of questions we just got about testing. And, testing, access to testing was really difficult at the beginning. Only hospitals could administer the test. There were a lot of restrictions, I guess, with the health departments of each state and testing. I don't know the details about it, but from what I was hearing on the air, since this entire 8-month period is kind of a blur since we're covering this day in and day out. David, I'm sure you know what I'm talking about. When you're in it, you're in it. So basically, I'm sorry, I just totally lost my train of thought, Natasha.
So you want me to ask it again?
Yes, please.
Okay. So how do you think the public's reaction to new information has changed from the beginning of the pandemic till now?
So the kinds of questions, again, that we got. So now we're getting a lot of questions from people, or people are calling in to try and correct our doctors and our experts because they heard something on a conspiracy theory video that was all over the internet. They're asking about drugs like hydroxychloroquine. I brought that up, yes. But, that news was also changing. At the beginning in New York, they were throwing the kitchen sink at everything. What was going to work? What worked for other things? We didn't really know much about the evolution of the virus. Science evolves and it changes, and you get more knowledge as you go along. In the beginning here, we didn't really have that much knowledge. We only knew what we were getting out of China, and that was also questionable by some healthcare providers and professionals who were looking at the data. People didn't know what to think, but we were doing the best we could. And then as it evolved, we were getting more peer-reviewed studies on drugs. We were getting more information coming out of these peer-reviewed studies, then multiple studies coming out, backing up studies that were there. So then you knew, okay, not just one study, not just one double-blinded study, now you have a bunch of them. And they're saying this doesn't work. But you have politicians out there saying that everybody should take this, when in fact, toxicologists coming onto our channel were saying, the side effects could be quite dangerous for people taking these medications. So yeah, there's a lot of stuff coming at people from all directions. But we have a beautiful thing on our channel that people are very careful to give the right information in the moment, discuss it with people, and not make anybody feel bad about the questions they're asking. Not say to them, you're wrong, and this is why. It's more about, okay, so you've heard that. Where did you hear that? Let's kind of go through this together. And it's a conversation with people. And whether or not they believe the doctors at the end of the conversation, I don't really know, but at least we're trying to educate through media and give people information that's real. And we have become a trusted source during the pandemic. And it's very important, I'll tell you, behind the scenes, that the producers working on this channel are really, really careful about making sure that we give people the right information, that our doctors are giving people the right information. It just is so important. We want people to walk away feeling like they're in good hands.
Definitely. Thank you. David, you're on mute.
So when I was working for CNN, it was 1985 to 1987, and that was during a period of growth during the AIDS crisis in New York City. And I remember one woman coming in who had HIV, and the entire newsroom camera staff refused to man their cameras because they were worried that she was going to infect them. And I walked up to her and I shook her hand, and she thanked me for shaking her hand. But at that time, one of the ways that I got the cameraman to come back to the studio was saying, hey, you take a subway every day. You're with people with HIV every single day in the subway cars. This is not how you get HIV. This is not how you get AIDS. And, you know, one of the things that I think we all experienced in the beginning of the pandemic was kind of a reprise of this kind of fear that, that drove a lot of people to, you know, believe the conspiracies, to believe the bad science. And it was really only after a lot of people started listening to people like Dr. Fauci and leading scientists that, you know, maybe the fear for some people abated somewhat, got to hear from the health professionals. But there's definitely this tension between listening to fears and listening to sensationalism and conspiracy versus listening to, you know, reputable sources. And we see this play out. I saw it in my studies of the 19th century cholera epidemic. I lived through it in the AIDS crisis in the 1980s. And we certainly see it today, this repetition of fears and superstitions having to be addressed by reputable health professionals.
But, you know, David, I think the challenge today is technology and social media. That in the 80s, we didn't have the kind of ability to communicate just anything we wanted to, regardless of its validity, to such a large number of people so quickly, right? So we had newspapers, we had radios, we had the bar scene where information was being exchanged. But, you know, I can sit here and send something out through Facebook and have 100 people then send it back out, and the same with Twitter, et cetera. So the danger today, I mean, and I was definitely, I had a partner who wanted me to quit my job. I was working for a primary doctor, a lesbian doctor, and a gay male STD practice in the Village in 1983 and 84. So, you know, so I definitely remember very viscerally what people were thinking and saying. But what scares me is what, you know, Melanie was talking about in terms of the callers and how that's changed over this time with, you know, QAnon and other stuff that's being actively promoted by quote unquote mainstream media and our president, you know, or the president rather. And there's nothing we can do to counter that. I mean, that's the part that's scary to me. Because there are just people who will not believe it unless they hear it from those resources.
Can I chime in on piggyback on what you're saying, Jackie? There is something that is concerning to me as a journalist, and I'd love to hear what Dr. Brooks has to say about this as well. Just because somebody has an MD, a DO, a PhD, an MPH next to their name, and, you know, has this degree, doesn't mean that they're an expert in the field which they're discussing in the news, online, whatever it is. You know, if you're an ER doctor and you're talking about epidemiology, well, you're not an epidemiologist. So finding out, just doing a little digging, you know, where did that person practice? Are they practicing in a private practice? Are they working for an academic medical institution? Are they publishing research on, you know, if they're an epidemiologist, if you're talking about super spreaders, are they doing research on super spreaders contact tracing? Is that their actual area of expertise? Have they published on it? Do they talk about it often? Are they a go-to source by physicians and other medical professionals? I often ask people when I'm trying to find an expert and I can't get them because they're obviously booked for something else, can you recommend some of your colleagues who've done research in this field that you think would be good to talk about this? I just don't want to go and find anybody. I want to find the right person to talk about something. You know, if you're going to be talking about, for example, medications that Trump has been given as reported by his physician, you want to go to somebody that actually knows about these medications, toxicologist, pharmacist, pharmacologist, whoever it might be, to talk about it, to discuss these things, as opposed to having somebody who's just some TV doctor talking about it without really knowing who this person is, what their agenda is. There's just so much built into even just finding that expert that's out there. And just because they're wearing a white coat doesn't mean anything.
Well, it may mean a little bit, but let me end.
A little bit.
So I'll comment briefly on that. When we had our national convention virtually, I had to introduce Anthony Fauci, so I did my little research. The man is one of the 20 top most cited researchers in the world. Okay, so he's not just a guy who got the job. When you were David, what he did, he figured out HIV, what he was doing. That's where he really nailed it. Then you look at this doctor, I don't remember his name, who is the president's lead, this neurologist or something, that's leading the COVID-19, like he's the primary source of information now. It's exactly what you said. He has no background in epidemiology, infectious diseases, allergy. So you ultimately, I guess I can smell a rat, and I honestly believe that the public can too, but maybe not. So what I would say is kind of go with what you trust. Okay, if Anthony Fauci says it, if it's wrong, it's because everyone thinks it's wrong. So I just tell people just go to a trusted source. And again, I really do trust your station. I was getting information from 110 Dr. Radio when I really didn't. I just listened to it because I just learned things. So I hope you are vetting your people well. So I, for example, have found that what I hear on that station, I trust. But it's tough.
Again, one of our librarians, John Oliver, asked the question, do any of you have thoughts about communicating emerging findings that have not yet been peer reviewed? And one of the things we're seeing is this, that's new, is these publishing of preprints. And, a lot of, whereas in the past, research findings would have gone through a peer review process and, so how do you help folks understand these emerging findings?
We do it. We do talk about preprint articles, but again, the nature of our channel is we have physicians who are doctor hosts. So they're able to push back. They're able to push back on the science. They're able to say, okay, but this is preprint. They explain what preprint means. They also ask about the research methods. We talk about research methods on the air to help people understand how to pick apart what they're actually hearing. How many people are in the study? What is your N of? How many people? If it's one person, that's not much of a study. That's just kind of a little bit of an anecdotal story, maybe one case study. But you have to really look at how large is the study? Who funded the research? Did the drug company fund the research? Was it done, they might have funded the research a little bit, but if it was done by reputable organizations, hospitals that are teaching hospitals, everybody has to get funding from somewhere. You can sort of understand if you're getting funded by the NIH, that study, I'm going to not be as hard on it because I know that it's coming from a place that's pretty stringently vetted. But if you've got a preprint article that's coming from some institution, you kind of take it with a grain of salt. But if it's interesting, again, if it bleeds, it leads. Sometimes there is a grain of public interest in what you're talking about. I think we did something that came out on COVID in the wastewater, and it was a preprint study, and it since has come out that there have been other things that came out after that. But we found it to be interesting. If this is something that was, just done in one area that could be expanded to more areas, that sounds like something that didn't seem invasive, didn't really bother anybody. And then my host was able to kind of push back with some of the things. And I don't really use preprints very often. If we do, we're very careful about it. We have somebody who's an expert actually come on. We do bring the lead researcher of the preprint article to come on because we want them to tell us about their actual research.
Mm-hmm.
I hope that answers your question.
Yes.
Yes, thank you. So we do have another question. We have quite a few questions in the Q&A. What past examples of infodemics have shaped the way journalists and health professionals navigate distributing information in the wake of COVID-19? And I think, David, you kind of touched on this with the history of everything and how you've been applying that as well.
Yeah, so come back with me all to the summer of 1832. That's the year of the first cholera epidemic in New York City. Then that summer, 2,000 New Yorkers died, which was 1% of the New York City population. And people didn't know what the cause of cholera was. They blamed sin, they blamed immigrants, they blamed the poor, again, in these rhythms that we see over and over again in American history. They blamed the atmosphere, the people who were businessmen and connected, people, journalists connected to business and party, and almost all of them were saying it's not a big deal, it's going to pass, and they were not upplaying it, they were downplaying it, and so this happened for many years until journalism started pushing harder to get the facts, and scientists started pushing harder. Eventually, in this battle against cholera, a man named John Snow, not the Game of Thrones John Snow, but this British doctor who should be more famous than than the Game of Thrones Jon Snow, but he discovered the cause of cholera, that it was waterborne, and scientific method was emerging, and the respect for doctors and science. And then by 1866, where there was the last big cholera epidemic in New York City, no longer were doctors and journalists and the public thinking about sin as much and blaming victims, but they were thinking about like how to disinfect outhouses, how to make sure that the sewer was not going to run into the drinking water. And so things really emerged over those like 30 years in the 19th century from a very superstition-based medical community where like there were these terrible cures, from leeches to ice water baths to rubbing mercury into the gums of patients, to then, you know, something that was very systematic. The New York City and all the other major cities had these bureaus of medicine where they collected data. They were very efficient in cleaning up the streets. They were sharing best practices in terms of medicine. And journalists and scientists and doctors were pretty much working together. They certainly had some disagreements, but there was this incredible evolution over 30 years in the 19th century that emerged. And by 1866, it was one more cholera epidemic, but it was the last major one in the United States, or certainly in the Northeast, because of this efficiency and this reverence for science and facts.
Wow, thank you. Thank you so much. I hope that answers the question. I'm actually going to combine a couple of questions because they're kind of related about Dr. Brooks, when you mentioned being indoors. So there's a couple questions about ventilation. One question was in reference to the comparison to restaurants, being in restaurants, and then with the NBA and how they're able to play indoors and things like that. And then another one is one of the students from the press history class did his research on looking at when the Spanish flu was upon us. They used movie theaters as places where people could receive public health education and communication. So what are your thoughts on just the whole indoor piece and ventilation?
So the NBA, in addition to playing indoors, is testing the players. So, and they're very rigid in their infection control. So I think if you really focus, you know, you test, you have ventilation, because you notice there are a number of people still wearing masks also, like on the sidelines. I believe that you can do okay. Restaurants, again, they're not, you know, they're testing, she said every 2 weeks, the woman Lana. So NBA, I bet they're testing every other day. So it's a very controlled environment. And then when you think, and it's funny because I'm interested in, I haven't heard David mention this 1918, 19. Maybe you did, but That was real interesting, at a real interesting time. If they were doing movie theaters indoors, I do believe that during the Spanish flu, they were wearing masks. In fact, there was a study that Philadelphia versus St. Louis, he probably knows about it, that it's a tale of two cities where they were wearing masks. It's funny because I don't remember which one was which. I think Philly, they did wear their mask. I hope so, since I'm from Philly.
No, in Philly, they didn't wear the
I
mask.
don't think they did.
They did not. Oh, well.
You're surprised by that, Oliver? Same city to throw snowballs at Santa Claus.
Yeah, I probably was at one of those games, but I didn't throw it. So I think that I have really no clear comment on them being indoors in movie theaters, because I don't know what happened. I mean, maybe when they did that, it gave worse outcomes. I really can't comment on that. I would just say that in general, indoors, you want good ventilation and you want to be protected. If you can wear an N95 and work indoors and not have to take it off, you're probably going to be okay.
Thank you. I have another question. Any suggestions to public health professions about how to keep public trust, especially from lay people when the information keeps changing, such as the information posted by Dr. Stella Emanuel, how to explain to lay people the misinformation even from a doctor? And I think, Melanie, you kind of touched on that a little bit. Excuse me.
I love phrases when we have people who come on because it is evolving. You know, what we know now, what the research says right now, and it can change. You know, we have little catchphrases like that, and even, I guess, we want to just make sure that our experts that come on the air can talk about things and in general. So giving really like the underlying medicine that we're talking about, and we really work hard not to have any partisan politics or any politics in what we're talking about. We'll use something as a launching point. So if I bring a public health expert on, I don't want them to ever be afraid to talk about what they know, because they won't be blindsided. They won't be in a position where what they're saying isn't trustworthy. But I think what you can do is stick to your guns, use phrases that let people know that you understand science is changing. And so what we know now, what studies are saying right now, but it can change. Just do that. And I think that that's totally fine.
Thank you.
I think there's a I'm sorry, David. Go
ahead, Go ahead, Jackie.
I think there's a challenge in that, though. It's that groups of people, for a variety of reasons, institutionalized racism, the history of medicine with people of color, etc., even when we crouch it in what we know today, you know, the question or the second thought for someone is, but what do you know that you're not telling us? What do you know that you're not telling me as a person of color, or me as a female, or me as a person who lives in rural America versus urban, etc., that there are all these other voices. And yes, we can only be, you know, people were washing their shopping bags at the beginning of the crisis and realized at some point in a timeline they didn't really need to do that. But there's still people who are doing it because we don't really, you know, the information is constantly changing. So, I mean, the challenge for all public health is we know what we know when we know it. And yes, with science, that information evolves or may change, like, and go in a totally different direction. So I also think that we have to be careful in how we put out our information from what, you know, with whatever degrees we have after our names, and also our own egos. I think a lot of what's happened with COVID, a lot of what happened with HIV, a lot of what happened with tuberculosis, which we haven't discussed at all, as well as cholera, is the ego involved in delivering the message as well. And you know, humility in our work, which then would lend to, I think, people are asking about issues of trust, et cetera, in the chat, would be better heeded or would be better received.
I love what you're saying, actually. That that makes a lot of sense. We do a lot of coverage on Black and brown health issues. We do a lot on minority concerns. We look at it as a public health issue. We do that, but a lot of places don't. And I think you're absolutely right. I think that I feel as a journalist that I'm not giving all of the information to my doctors to put on the air and to do on the air as segments if I'm not covering all people who are affected. And it's hard to do that. Don't get me wrong. When you're trying to push information out, if it's breaking news or if it's something that's the topic du jour, it's not always easy to get to all of those angles, but we do make an effort to make sure. I also make an effort to make sure that I'm bringing on experts of color. I do that. That's something that I purposefully do because I want to. And I feel that it is in my position as a producer that I can. And I'm using it for the greater public health good. And I don't know that all journalists see things that way, but I can only speak from my own experience that it's something that is not done enough. And I'd like to see more of myself.
Okay. All right. To that point of public trust, there's a lot of talk among within communities of color about vaccine trials. And on the one hand, groups like the National Medical Association have stressed the importance of diverse groups of people participating in vaccine trials. On the other hand, there's this mistrust that comes out of the history of things like the Tuskegee syphilis experiments. So what do you say to folks about vaccine trials? And also, what about this rush to bring vaccines? These predictions about when we're going to have vaccines and the trustworthiness of that process. So,
I could just say really quickly that one of the things that we've mentioned on this panel, and you can't really mention it too much because it's something that underlines everything that we think about the disease, is that we have a crazy precedent. I hope that's almost a nonpartisan statement, because we have someone who is not reliable on the medicine. And so we're really at a disadvantage when the most powerful person in the country is really using misinformation on an almost daily basis. And certainly there are issues. I could completely understand why a person of color who has this tradition of knowing Tuskegee experiments, and also just even the way that COVID has played out the inequities this year, would be suspicious of what a hospital would do, the way that a doctor will see a person of color versus someone who's white very differently. We see it playing out in the last couple of days when I heard there was some boss who came back from top medical care, took off his mask and entered his house and expected everyone who worked for him to take care of him. We have these inequities built into the system that are only exacerbated by the president's misstatements. I know people who are very pro-vaccine. I am one of them. And I'm, the day that Anthony Fauci tells me to take a vaccine, I will. But there are other people, including the president, who might say, if this vaccine is safe, I'm going to wait till Fauci to tell me it is, because we're living in a time of extraordinary misinformation.
I can speak a little bit to that also. So what I tell at least the African American community to whom I may speak, you can't have it both ways, because there was complaining about the fact that we're not in clinical trials. You have all these medicines out there. How do you know they work on Black people? And that was, let's say up until this year, that was the complaint. So now it's like, oh, I don't want to be a guinea pig. Okay, so yeah, right. So I also think about this, may seem, I don't know how it seems, but I look at, well, there are a whole lot of white folks that are in those trials. So, if you're really worried, you're in the same trial as all these people that you're worried about. So you can at least, think, I mean, if they said we're only doing this trial on Black people, then I'd be probably a little concerned. But we really do need African Americans in it. And so we at the NMA are trying to say, hopefully we'll be the Anthony Fauci as it relates to the clinical trials, at least someone that they can quote unquote believe. Now, the other question about the rush to get a vaccine to market. Okay, I happen to sit on the advisory committee of immunization practices that is advising on the vaccine, and I'm also on the FDA panels that discuss this. And I can tell you that there is even tension in there. We want a vaccine that is safe and effective. I'm pro-vaccine. The worst thing that could happen would be a vaccine hits the market, they say it's safe and effective, and it comes out and there are problems. No one will get vaccinated from any vaccine, even if we had 1 million people in the trial and 99.9% of them did well. So there is great concern in the medical community about putting a vaccine on the market that is not safe and effective. There was even guidance, it's interesting, there was guidance written by others, I guess I can't really speak to them, that said this is what we think should be the criteria you use to put a vaccine on the market. So there are a lot of people, I'm gonna say like me, who are pro-vaccine, who are doing everything we can to ensure that the vaccine is safe and effective. And some with you, David, when Dr. Fauci or these other, I work with people at Dr. Fauci level, when they say this is safe and effective, I can believe it. And I evaluate the research on a bi-weekly basis. So we get the reports, the pre-stuff, as Melanie would say, the preprints. And then they say to me, well, can we see the preprint? And really, the answer is no, because you may have done the first 1,000 people and had a lot of problems. Then you do 30,000 and you find that didn't pan out. So then people start to, is there something you're hiding? So no. I think the key to all of this, a lot of things we've been discussing, is transparency. Somebody said, what is it you're not telling me? I'm telling you everything I know, more or less. I mean, there you go, what else? But in general, just be transparent and be objective and be, to me, dispassionate. I mean, this is what is, not what I think. This is what the information I'm presenting to you, what I know, not what I believe or what someone else believes. I'm giving you dispassionate, objective, transparent information. This, like, I was concerned when, again, the leader at the most powerful office in the land said, I don't want to scare the people, so I'm going to downplay the virus. No, you scare people when you downplay it. Oh, it's really nothing to be worried about here, people. So that doesn't work. So as it relates to the vaccine, we're really, really struggling with this, because the studies show that somewhere between 30 and 50% people say, I'm not going to get vaccinated. So we work really hard, spend $8 billion, get a vaccine that's safe and effective, and people don't take it. So that's my other nightmare, that we do everything right. 30,000 subjects in a test in a phase 3 is a lot. Okay, so that's a good number. But we do all that, do all the studies, triple check it, independent review it, send it out to another area for a second review. It's all fine. People, I'm not getting that thing. So we're working very hard to ensure this is done correctly.
I have to say, I'm landing in the middle on the vaccine. And I'm like embarrassed that I feel this way. It's great that the pharmaceutical companies and the researchers who are working on it have collectively said, we're not going to rush this through. That has given me a lot of hope that regardless of other powers that be, in particular, the occupants of the White House, that the pharmaceutical companies are going to do the right thing. I think prior to that statement, which was just a week or so ago, I wasn't clear. I wasn't sure on there was motivation of general good. Hey, we need to find a vaccine. We need to then figure out, the trial process. And then if the thing works, how would we distribute it around the world and who will get it at what stage? But then other things were coming in. And I think this is the power of the public voice, listening to Trump, listening to other people other than Fauci, who were like, well, if we have a vaccine, we just need to get it out there. No, we don't. We don't. I'm pro-vaxxer. I think people who don't vaccinate their kids should be held criminally liable for anything and everything that happens, not only to their children, but to anybody else's child that the kid exposes them to, etc. But I do think that we need to get this right. We've got to get this vaccine thing right, because I think it's a tipping point. And I think that if we don't get it right, I think the pharmaceutical companies have to keep saying, we're not going to rush this. We want to get this right. And so that goes back to answering your question about POC, people of color, being engaged in the trial process. I constantly say to people, you got to sign up. Got to sign up for things, and whether it's this trial, this clinical trial, or some other clinical trial, as Dr. Brooks already said, you can't have it both ways. You can't complain about how we're not a part of the process, they never come to us, and blah, 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 and then when we do, or when they do, oh no, man, thanks, I know about Tuskegee, or La Operación, or Nestle, and the milk thing, or whatever, and whether or not they even know the details, they know something happened. So we have to work more and better on getting people educated about the importance of clinical trials, and for all kinds of people at different ages and races and stages to participate in them. But we also have to be able to trust the pharmaceutical companies as well.
I haven't really chimed in on this. I've been listening to everything that you guys have been talking about. My doctors don't cover the vaccines. There are other shows on our channel that do cover the vaccines. We have a Grand Rounds medicine show where the head of the Department of Gastroenterology has a grand round show, essentially bringing top experts who are working in the field to come in and talk about this, as Dr. Brooks knows. So we bring in folks that are vaccinologists. They know about vaccines. Dr. Fauci has been on our show our channel a couple of times. Paul Offit is also a well-known vaccinologist who's been on, he's a frequent guest on our channel. And I feel like he is one of those people also that when he's talking about it, you can kind of trust what he's saying. I don't have a whole lot to say about it, but I like what everybody here is saying about it.
And I'm just going to say, I agree with what you said, Jackie. I have my own concerns, quite frankly. That's why I'm not, when I give my opinion, it's not going to be what it's supposed to be. It's going to be what I really feel, synthesizing everything. And good for you, Melanie, having Paul Offit in our field walks on water, okay? So, he's the man. If he says it, you can be comfortable with it.
Dr. Patterson? You're muted. You're still muted.
Sorry about that.
Okay.
It was not doing it. So we have a couple of questions we want to get in. One was about the mask education. So there's a question that states, do you think that early recommendations on not wearing masks were a result of the limited supply to conserve masks for healthcare workers, or was it simply due to having less knowledge than we have now? It was really difficult for me in the beginning of the pandemic because my parents were trying to purchase medical supplies, and I was very trusting of Dr. Fauci's recommendation not to, and suggested to them that it was not necessary. But then not a few months later, we are all now wearing masks. And I believe it led to a disconnect for many Americans, leading to people thinking, seeking out false conspiracy theories about mask wearing. So the thoughts about, I guess, the
real briefly.
beginning about masks.
So in the beginning, and this is again, maybe the journalists can recall, we did not know there was what we call community spread, which now we're just assuming. So when there was the concept of not community spread, in other words, if someone had it, they either been to China or been around someone that had it. So when there wasn't community spread, we really weren't as worried about masks. Once that hit, I remember thinking, man, I bet you this thing's gonna be community spread. And that's when all bets were off. So I don't think it was because we were trying to conserve masks for the general public. The most embarrassing thing, I was on, not the cover, but the inside of the LA Times with a bunch of people wearing masks. And I had on my white coat and a stethoscope and no mask. I'm like, how did that photographer do that? I took it off a couple of times and he took that picture of me and they put that, I wanted to call that man and call him every name I could think of. My friends were texting me, great that you're in LA Times, but you don't have a mask on, man. Good luck to you, man. I hope you make it through. So it's like, so we didn't know. Science has evolved, okay? So I don't think it was preserving PPE for healthcare workers.
Thank you.
Can I jump in, Natasha? I have something that was sort of an interesting spin from that as well. Because that was going on, once we knew that we needed to wear masks, I also run the social media for our channel, and I wanted to figure out a way that we could get all the doctors involved to show that they're wearing masks, but in settings that are not in the hospital. So I would have them take pictures, and we would post their daily photo of whatever they were doing, walking to the studio, maybe with their kids or whatever it was, but we would have them wearing masks. And then we asked our listeners and followers to also post their photos of them wearing masks. And it was this way to get people involved and help normalize mask wearing. And people were excited about it. You know, one was saying, I made this mask, or I'm selling them to friends, or I'm donating them to a nursing home, whatever it might be, to try and normalize mask wearing, because it was a little hard at the beginning. I wore mine all over the neighborhood. The second we were told to wear masks, I was wearing it. Nobody else in my neighborhood, which was about 2 miles from one of the big epicenters in Queens, New York. And I just thought, well, I'll be the weird one. I don't really care. I'm going to do the right thing. And now everybody here is basically mask compliant.
Awesome.
Thank
you. You had something, Dave?
Yeah, just really quickly that, I think that I've predicted the demise of, the political demise of Donald Trump dozens of times, and I've been wrong every single time, starting with when he, said that I prefer war heroes who are people who are not captured in 2015. But I'll make one more prediction that I do believe that when he took off the mask and entered the White House, that on a very visceral level, mask wearers around the country understood the risk that he was putting his staff at. And I think that, I think that this could actually be maybe the most politically damaging thing that he's done since he achieved the presidency, just because it's what we talk about all the time, right? We're no longer washing our vegetables, maybe, but in our grocery bags, as Jackie mentioned. We're all grappling with mask wearing, right? And so when you see someone who not only might have it but does have it, walk into a crowded White House, or drive around in a hermetically sealed car, it brings something home on a very visceral level. And journalism, particularly television journalism, can really convey that in a way that that other media maybe cannot.
David, I wish that was true. Oh God. Unfortunately, though, we know what the other side of the aisle, let's just say, is doing. that whether or not they acknowledge it, they will immediately dismiss it. And our ability to retain information, you know, man's greatest ability is the ability to forget. Thus, women can become pregnant more than one time, right? So people are not going to hold on to this. They're not holding on to the fact that he pays hookers. They're not holding on to the fact that he's an overt racism. They're not holding on to the fact that he couldn't call out white supremacy just last week. They're not going to hold out. But I wish they would, but.
Well, as I said, I've been wrong so many times.
Okay. Okay. I'm sorry. We're short on time.
One more question. One more question we'll do before we wrap up. This one is about exposure notification and contact tracing with respect to the phone apps. So I don't know if you guys have heard anything about this or know anything about it, but exposure notification, which is supposed to let you know if you've possibly been exposed to someone who has tested positive for COVID. And the question is, you know, does it mean that it's the first or the second person or the third person? It's really difficult to understand the information that this app would share with a person. So if they were to turn on this notification app on their phone and they go into, you know, a place and the app notifies them that somebody near them has tested positive. Any thoughts on this or experience? None.
I think New York City just, I think on Friday, announced that they have this going on. I think it's too soon to tell. I don't think we have enough information yet.
I think that it's a mistake at this point. I think there's too much that we still don't know, and to just have somebody's phone, buzz, it's way too anxiety producing. It's too much information with no information at all. So I think it's a mistake at this point. And I think this is one of the problems with being an early adapter as well.
Mm-hmm.
Just chill. Just chill for a minute. So.
Yeah, I think so I think I received some emails about it, you know, advertising and trying to get people to download it to their phone and things like that. So it'll be very interesting to see how that plays out. But yes, it is very early in the game for it. That's why I was asking if you guys even had any experience with it. But I do, you know, we did have a lot of questions and, you know, I wish we had more time, but you guys did a really great job with sharing, you know, so much information. Kim, you had something?
Well, I just one question that came up that I think feels a bit urgent. So I hope you don't. Ron asks, says, my uncle is an electrician in New York City and his job does not allow masks with respirators. Is it true that the mask with the respirators are worse to wear than a mask without one because of how it breaks down the virus? And because we're short on time, I'm going to direct that to Dr. Brooks.
Mm-hmm.
So you mean the respirator, the ones that have you can breathe in and out things?
Yeah.
So what it looks like first of all, those are, if you're wearing it, that protects you. I think the concern is that when you exhale, you may be exhaling virus, and that's the problem. So if he's wholly self-centered and self-oriented, then he's okay. What I do with those is I wear one and then I put a protective over it. You know, what people call surgical. Those that you're talking about generally N95s. So I'll wear a respirator N95 and I'll put a standard surgical, the blue ones that you see all over the place. And the one just basically, if it's a real N95, it has two separate bands that go here and here. If it goes around your ear, it's not a true N95. A KN95, which is Korean. Yeah, so I would recommend that if he wears his respirator, if he has a respirator style one, just put a protective over it. And he should be okay.
Thank you.
Thank you.
Mm-hmm.
So thank you, everyone. Thank you for our audience for joining us this afternoon. Thank you so much to our panelists. We appreciate everything that you've shared with us this afternoon. We thank the audience for all of your great questions. And you know, this is a conversation that'll continue. Hopefully everyone will be able to take something away with them today that they can use and that is valuable to them. But we are definitely appreciative for everyone taking the time to be with us this afternoon, especially our panelists. Yes.
I also wanted to add my thanks. We called in personal favors to put this panel together. And I just wanted to let folks know that we did record this. The recording will be available, and we'll also be having some social media conversation around this as well. So thanks again.
All right.
Thank you.
Thank you. Thank you.
Enjoy your evening, everyone.
Yep.
Thank you.
Thank you.